And I like that because you're very good at what you do. And I don't ever try to go into your lane. I want to stay into my lane. But I do think there's a gap there between physical therapy and training. So anything that we can do to kind of close that gap, I'm all for. Hey, what's up, everybody? And welcome to Shit Trainers Say, a regular podcast brought to you by Catalyst Personal Training in University City. Where we talk about, these are usually typical conversations that we have with our clients that we felt you could benefit from the knowledge. And today we have the privilege of having Joanne Macza and Sam Youssef with Boutique Physio. They are physical therapists and, in my opinion, some of the finest in St. Louis, the finest in St. Louis. I think Joanne is. She is unique in her approach. She does a very hands-on approach, a very educational approach. And so it's not just where you go in and she spits out some exercises and tells you to go home and do these 3 times a day, 20 reps each type of physical therapy. It's much more involved and invested than that. And as a result, she gets better results. So that's why I think she's the best physical therapist in St. Louis. So Joanne, Sam, welcome to the show. I hope you can live up to that intro. I know you can. So you're what's that?
We can end right there.
Yeah, exactly. Thanks, everybody. Thanks for tuning in. And Joanne, you want to tell everybody a little bit about your shop and where it is and kind of what you do and why your approach is unique?
Yeah, so I am in U City as well. Great neighborhood. And we've been here almost a year and a half-ish, right, Sam?
Yes.
Yeah, roughly. It's a self-paying practice. There's no insurance involved. It's one-on-one, hands-on care. You have the whole entire time that you come in with myself or the PT who's in-house. It's very manually driven. So the techniques that I use are all manual, hands-on techniques to help mechanically advantage the system to properly allow your body to do the movement patterns or even to get an activation or a contraction through the muscle that maybe is an underperformer. And my big focus is on spinal stabilization and facilitating that through my techniques and enhancing that with the exercises that I do. So I'm not a heavy exerciser. I probably have like 6-10 exercises in my repertoire that I tend to give my patients because I find they're all doing tons of exercises and they have people like you that can exercise them really well. So I don't want to be that role and I don't think I need to be that role. I'm kind of just facilitating that role is kind of how I see it.
Yeah. Okay. And I like that because you're very good at what you do. And I don't ever try to go into your lane. I want to stay into my lane, but I do think there's a gap there between physical therapy and training. So anything that we can do to kind of close that gap, I'm all for. So,
and I told you that the day I met you that I didn't want to do your job.
And vice versa.
Yes. And, well, and that gap is the communication aspect of it, the recognition and then communicating what roles each of you play and then how you collectively help support your clients and or patients in developing whatever program or whatever their rehabilitation side of it is. And that's always has been lacking from my perspective, is that openness and ability and wanting to communicate. And well, but it's a wanting not to understand from some standpoint, where some PTs, take the role on as like, hey, I could rehabilitate and help train. And then some trainers take on the role as I can help rehabilitate and push through this dysfunction and or injury to get through to the next level. And, and inevitably it ends up holding that particular person back unless you have an open communication between the two parties. So.
Absolutely. Where the two expertise kind of meet in the middle for the benefit of the patient and the client. Yeah, that's our whole goal at Catalyst. And I know that's your goal there at Boutique Physio as well.
Yeah, which is why we get your trainers that come in and kind of join in their client session. And I love it because It gives the chance for the trainer to kind of understand what I'm doing. It gives them the chance to ask the questions, and it gives them the chance of utilizing that in the training environment. But the patients love it too, because they feel like they had this great opportunity of bringing the two parties together. So they feel much more confident that what they need to get done is getting done.
Yes. Yeah. And that's what it's all about, is producing results for the client and the patient. So tell me what you guys have been seeing more of since the lockdown. People are moving less, people are working from home, and they're just not as physical. They're not moving as much as they used to. So have you seen an increase in certain complaints that people are presenting to you?
I think overall we're busier, surprisingly, which, and when we look back, we're not surprised anymore, because of the fact that people, they have more time on their hands to deal with the problems that they had. They don't have work and kids and other obligations to stop them from, hey, I need to take care of that. So maybe that has allowed them to have the opportunity of, hey, I got the time to do it. If I feel safe in the environment, I'm going to do it, because I'm an essential practitioner, essential service. There is the nagging symptoms that they might have had before might have rose up a little bit on the priority list because they don't have other stuff to pay attention to, or it became more noticeable because they're not moving as much and they can't do their typical gym routine, and they can't go to the Pilates class live, and they like the virtual, but maybe it doesn't produce exactly what they want it to produce for them. So as a result, they have to kind of feel like they have to do more to maintain how good they feel, and they feel like they're stiffer, more rigid. So anything mechanically disadvantaged, which is all of my world, becomes a little bit more noticeable, and they start to get tighter and stiffer and tension, and the pain that was there starts to rise up a little bit, but they have all this other rigidity. So all mechanical restrictions become a little bit more noticeable in that world.
So can you give us an example of what a mechanical restriction or disadvantage would be that you see commonly?
I see a lot of lumbar pelvic hip complexes. I think a vast majority of my practice is that. I treat everything. So people, I was like, oh, I feel really good in my back, but do you actually treat shoulders? It always perplexes me when people ask me that. But so I see all body parts, just to put it out there. But I tend to have a lot of clientele that get pushed my way for lumbar pelvic hip dysfunctions. Why? I don't know. Because when I started practicing, I didn't really love treating the back, to be honest with you, because it felt like this, I don't know what to do with it. And now that's all I do, or majority of what I do. And one of the other reasons why is because even if you have a shoulder problem, I always feel like there's some type of relationship to spinal stabilization. So I'm always looking at the lumbar complex and the pelvic complex. Okay. So it always comes back into the realm of it, which in my world without insurance is beautiful, because I don't have an insurance company governing which, piece of the body I get to look at and treat. I get to look at it all, and I became more aware of analyzing how it all kind of works together as a unit. So I see, when I talk about a dysfunction or a restriction, we're talking mechanically. The lumbar spine is more restricted with what it can do from a rotation through the segments of the vertebrae, and the pelvic ilium sacrum complex doesn't maybe sit balancedly. There's some restriction patterns. Maybe it looks beautiful and it's balanced, but when I go to move my leg forward, when I want to take a step, it doesn't move the same degree or the same pattern. There's certain type of movement patterns that should happen in an osteopathic way. The joint, when you put your leg forward, the pelvis ilium has to do X movement, and it has to have this much ratio versus X. So there's very much a mechanical specificity to it that we analyze, which is why I say I look at how people sit, stand, and walk all day, and I teach them how to sit, stand, walk all day. And so I'm trying to build that mechanical advantage, because if you do not have the mechanical advantage and there's a dysfunction in the way those joints move, it's exactly like a car, something will not work well. And that's usually the muscular system. And primarily the first culprit is always the core stabilizer, and more specifically multifidus.
Yeah, and that is, and I can attest that you watch people walk, stand, sit, because you did it with me, because I mean, you taught me a lot. I mean, number one, you helped me with my squat. That was a real eye-opening moment for me.
And considering
because I've been squatting for decades. So I'm like, I know how to squat. And you're like, no, you don't. And so I was like, oh, shoot. So yeah, so you taught me a lot.
The biggest culprit, right?
Yeah.
You can see so much, and this from the gym where you are, your business. You can see so much from the squat in the sense of what doesn't work well. And, sometimes, and you see this all the time, probably, like you're trying to get that person to do it. And you're like, why the hell? I give you the cues and I know you should be able to do it, yet they just can't quite figure out how to get their body in position. Typically that's a joint restriction, typically. Yeah. And so they just don't have the capacity of the joint to get into those positions to do it. Right away, you're at a disadvantage because you're not going to get multifidus stabilization on that spine. And as soon as the spinal stabilization is in the second position, you're in for some type of funk. It might not be right away. Give it 5 more years, give it 2 years, and it turns into something.
Yeah, and sometimes it could be something as benign as bending over to pick up a pencil that causes it to go out. But, I agree with you on the squat, because I feel like I'm pretty good at watching other people move and saying, okay, X, Y, Z, but I'm terrible at analyzing my own movement. So
you're not unlike anybody else.
Right. Yeah. Because I can't watch myself move, right? Everything is kind of internal on that kind of software, that movement software. But, and the other thing I like about you, and I appreciate you, is that you totally geek out on this stuff. So, but I usually try to put, but I try to put it in layman's terms for my clients. So the way I see it is that when you talk about the pelvic lumbar kind of complex, it's, if you can't get the movement from your hip, then you try to get it from your low back. And if you can't get it from your low back, then you try to get it from your hip. And if you can't get it from either one, then you're going to try to get it from somewhere. And that's where you run into problems. So basically you identify which one is either the lazy muscle or the restriction in movement, and try to get that moving, correct?
Correct. And, just to give an example, today I had a patient for the first time. She's had pain since 2016, has had multiple treatment approaches, seeing me for the first time. And now she's got so many different layers on it, right? It started out as left posterior lateral back hip pain, went to front hip, had that for a long time. Now it's right front on top of it. So as I'm analyzing her, I'm writing on my whiteboard what I see, and I'm telling her, well, what's going on this side is slightly different than this side. And this side, the driver is your lumbar spine. On this side, the driver is your ilium on sacrum. And, I'm kind of explaining why in the end, you have to clean up the whole thing. And I really heavily work on prioritization of what I think is, because I don't want to work on the third string player. I want to work on the first string player. And so I kind of clean it up that way because it's faster. And then I can get a multifidus activation to kick in faster naturally as I feed her what I need her to do for me. So,
I like that. And I think that's really important to identify, because muscles move bones, right? And there's so much to that, because for the longest time, I thought the pelvis was just one little bowl. And what I know now, and partially thanks to you, is that I know that it's actually 2 halves that can kind of rotate, right? Yeah. And they can kind of get off kilter, and then that sets you up. I mean, if you think about, if your pelvis is supposed to be like this, and instead it's like this, that's going to cause some issues, that asymmetry, right? And then the other thing that, and so you have to, muscles move bones, so you have to change the the tension and the tensegrity within the muscles to get the bones to shift, correct?
Correct. And then it's interesting you say that, because people always say, well, the pelvis doesn't move. I mean, I went to a internal medicine doctor and I met with him and he's like, I didn't know the SI joint moves. I'm like, I was just like perplexed on that. Like how, I mean, and this is the, you know, people don't think you have movement there or shouldn't have movement there. And a lot of these, hey, I'm hypermobile in my SI joint. In reality, what I find when I assess them, they're actually not mobile. They're actually immobile in maybe different surrounding areas that makes this relative hypermobility where they think it is. And so when you're walking, your one side of your pelvis is doing one movement and the other side is doing the other movement. It has to move to walk, okay? Because if you ever see somebody who has a fused pelvis, you'll know. You will see it like a, you know, it's like the rotten apple in the basket, because it is extremely obvious for the layman to figure that out. Yeah. So you have to have movement in these areas. You don't want too much movement, but you know, everything's relative. For the most part, I find people are restricted or hypomobile versus hypermobile.
Yeah, they lack mobility.
Hypermobility, we need stabilization anyways. Mm-hmm. So, you know, there's this little bit of a balance component always really there.
Yeah, I like that. And then the other thing that I appreciate about you, and I didn't really appreciate it till I got to know you, is that like when you talk about the multifidus. So the multifidus is the little tiny muscle in between each vertebrae. Actually, there's two, one on each side, correct? And they're little tiny muscles. And it's kind of like when people come into me with a rotator cuff issue. So the rotator cuff are these four little tiny muscles that surround the shoulder joint. Well, a lot of people want, well, you just need to strengthen your shoulder. So they get these big weights and big movements. But what happens is after you cross a certain threshold, those tiny muscles, those little muscles can't handle a load. So they hand it off to the bigger muscles. So you're actually not doing anything for the rotator cuff. And so the same thing is true with the multifidus and spinal stabilization. If you use too much weight or too big of a movement, then those bigger muscles like the spinal erectors and everything and the QLs and all those kick in instead of acting and activating and strengthening the multifidus, correct?
You know, I'm sitting here smiling because you are the one person that gets that after hearing me say this till I'm blue in my face. But there's this lack of knowledge that you have now gained where there's this more and let's make that core work harder and harder. And when you actually test whether you have stabilization in your spine, more does not produce better stabilization in the spine. It actually does the reverse, because it'll literally hand off the workload to its next door neighbor, which is the erector spinae and the QL, depending on what your activity you're doing. So spinal stabilization is kind of this little beautiful, important, most important thing, but it has its maximum ability to handle a load. And if you give it too much, it often gets too much. It kind of brings its second workers into the play. So and when you don't have it, that's invaluable. When you have it, that's not as valuable. That's not as big of a deal. But when you don't have it, which is a mass majority of people, it's a big deal, okay? And most clients come in and they're so overloaded in their secondary system that they can't even figure out. I always describe it to them, it's like this New York skyline. Is this building tall already? Or is this building just too tall beside it? Unless you bring the erector spinae down, you might realize that, oh yeah, that core is really working really well, because it's already doing a good job, but it's so masked by the other stuff, right? So that's what happens in an inefficient system. That's obviously what I see mostly. So it's extremely valuable because there's this recruitment inefficiency that is every single patient I see, they have a recruitment dysfunction because they're in pain and they have problems, etc. But you'll see it in the mainstream population to some degree where they just don't have that primary catch in the stabilizers, like one split second before everybody else comes into play. And that is the game changer.
Right. Well, and because that sequencing is key, right? And what I mean by sequencing is the sequence that muscles activate, right?
It is
Because a lot of people that have dysfunction, especially in their, say, their lumbar spine, their low back, is because they go straight to the second step of the sequencing and they skip the first one with those little tiny intrinsic muscles in between the joints that really kind of lock those vertebrae in place and stabilize them. They go straight over that one to the bigger muscles, correct?
So all of my patients have this inefficiency. Whether they started it with it or they ended with it, I don't really know. And at some point I don't really care because they don't have it. And so it is the game changer in the fact that that has to be trained out. And so the dysfunction then the restriction starts to cause it to happen and then continue to make it happen, right? And I will tell you, every single time I see a patient, they have it, but they don't necessarily have it on either side. So some patients, I tell them, like, you know, I could tell them, don't tell me what side your pain is on. Just tell me about the pain from a description, but don't tell me the side it's on. And I can test them and I can tell them which side they're having the dysfunction on based on the fact that they don't have stabilization recruitment patterns on that side, yet they will probably have it on the other side. So their sides don't match, okay, for this stabilization complex. And so when I teach them an exercise, an activation exercise, I'll say, okay, do the right side when you do the activation and then do the left side. And then when I tell them, okay, you do better on your, like my patient this morning, she had better stabilization on her right side than she did on her left side. So I said, when you do your activation exercise, you start with your teacher side and the second one is your learner side, because you need that neuromuscular system to activate. You know what it feels like. It feels kind of good. It just kind of glues in. Yeah, I feel it. Okay, now do the other side. Doesn't feel the same. Do you start with the right so you can teach the left? Start with the right so you can teach the left. So I tell my patients which side to start their exercises on. And when they start to not be able to differentiate the difference, then they can do double. They can do a double team. So I don't let them do a double press on the exercise unless they have built this relationship difference, and then they minimize the relationship difference.
Yeah.
So I'm very picky and strategic about how I go through it.
So just a comment, you know, Jim, one of the things that we were talking about early on when we were talking about the integration and collaboration of the two practices is that seeing how important it is from a performance standpoint or enhancing performance, and, you know, kind of getting into your realm of working with your clients, is you see that, you know, working harder doesn't necessarily translate into increased performance or better performance without going through the details that Joanne was just, you know, talking about and detailing. But you could also see that how significantly important it becomes in those initial stages to properly assess, and as you're developing a program, looking at what's weak and what needs to get strong, and, you know, collectively how to put that program together. And so I think, you know, we've been talking about this for years. We really haven't had the opportunity to implement it. And that's kind of one of the things we talk about as we progress, is how do we integrate those two aspects and sort of look at that Venn diagram where that overlap would be most beneficial. And it's not something that you start with and finish and then hand off. It's something you start with and it kind of goes back and forth almost like a pendulum, because as an athlete or somebody progresses in training, you're then looking for what that next step is going to look like. And that collectively brings, you know, both of you together again to look at how do you enhance or get to that next level of performance.
Yeah,
I think
absolutely.
the question you asked too, that you was like, what have I seen over COVID? I think people are just like, they're kind of dewired anyways. And I think that they might have some mild dewiring to that stabilizer. And then this just like completely threw them off the track. It's like they took the plug out of the wall, right? Mm-hmm. And so I always say that when I'm teaching them exercises, I'm like, I'm just mapping your brain out. Like, yeah. I'm not going to strength train you. I don't need to strength train you. You're way stronger than I am. And you don't need the strength training. That's not your function. That's not your default. Your default is you don't have the wiring set up to kind of find that guy. And whether I need to mechanically help you find it or just facilitate with a directional specificity with how you activate it and wake it up, it's kind of a little bit of both piles.
Yeah, and I like that. And that's really important, because when you say dewiring, I see it as like the muscle just, for whatever reason, just doesn't turn on. It's like the on-off switch is broken. It's disconnected. There's no electricity going to that muscle to get it to activate. And so what happens is then the surrounding muscles, the kind of big brother muscles, have to step in and take up the slack. And the other thing that you mentioned was mapping your brain, because what a lot of people don't realize is that a lot of these movement patterns that they do run in the background like software. And so when you get caught in a dysfunctional movement pattern, it takes a while to fix it, because not only do you have to find those muscles that are dewired or not firing properly, but then you also have to install a new software program. And that's why it's difficult. And that's why, like, the teacher side and the student side, the teacher side has the wiring and the software down. And then the student side is like, I'm writing with my non-dominant hand here. So you have to kind of train that. So I really like that. So I want to get into—
the other thing is, you know, you live in a world without mirrors. I exercise in mirrors because I do yoga, and probably I'm more vain than you, I don't know. So the other thing about it is it's great to use, but a vast majority of places don't have mirrors. And it's almost better in a way, because I tell my patients, don't worry about it. You know, I used to be posture is extremely important to me, okay? But I've gotten away from, hey, this is where you should be. And people are like, okay, what does it look like? I'm like, don't care what it looks like. Just know what it feels like. When you're in the right position, it will just feel different. Whoops. I lost you here. One second.
Okay.
One second. Hang on one sec, I'll get back. I don't know where the heck it is, but. Oh, there we are. I think I got you. There we go. So I just say, don't worry what the posture looks like. I kind of want them to lower the posture, but if I see that they're just not they're getting too stressed out about what it should look like in the mirror, that's not going to help my neuromuscular system get to what I want it to be like. And they're so overloaded anyways. I'm like, just feel what it feels like. Just start to know your little zones of where it should work and the sensation, and build this new relationship to what it feels like when I'm working something too hard and too light. And I'm telling them, this is what it should feel like. And I describe it. This is what it shouldn't feel like here. If it feels like it's a lot more tension in this zone, chill it out, you know. And I start to educate them on this relationship of a sensation, because some people learn differently. You know, you can tell somebody to bend your elbow, and you can tell them to bring your hands to your shoulder, and you can tell them to do it 5 different times. It's the same movement, but people do it differently with different words.
Yeah, I agree. So, and real quick, let's get to, and I know this is a terrible question for you. I know that ahead of time, but I want to satisfy the curiosity of the listeners. So what causes that dewiring? And
oh, God, that's a loaded question.
Right. and then what are some easy fixes that they can do in their daily life to either prevent it or keep it from going back?
Good questions. I mean, these are questions everybody asks me every single day. So what causes it? What causes it? It can be very specific to that person, depending on what they come in for a complaint. It can be so many things, from I fell to I tripped to I almost fell to I had no injury. It slowly came on. There's so many layers to it. It is sometimes a very slow dewiring that you don't even know, because it spanned over 2-3 years. Some people have some knowledge of some type of event. You'll never pinpoint 100% that it actually came from that, okay? But there's a high probability that, you know, I used to always guess. I mean, it's like a little guessing game. I kind of like to say, like, probably, and you don't really know. I mean, there's no real no, but it becomes this slow, gradual event, or else it's a traumatic. That's literally 2 little piles it fits into.
Yeah, I agree. You know, usually, like, the triggering event, the event that pushes them over the threshold is usually, like I said, some benign thing that's could be totally unrelated to it.
That's why I think they're dewired already before it happens.
Oh, no question.
That's my answer to that.
Yeah, no
Yeah,
question.
they already had some dewiring. That's why it's like, why would a Kleenex do that? Because you're already in a spinal stabilization inefficiency to some degree. You just didn't really notice it, and that kind of tripped you up.
Yeah, put you over the edge. So what are some things that people can do at home to either prevent from going into this type of cycle or pattern, or keep themselves out of it?
So if I had to put it into, hey, they aren't at a mechanical disadvantage, because that's going to minimize their ability to do something for themselves, or a little bit, maybe not all. My big thing is, I don't care what they do at the gym, Jim. I do. I don't care how much they work out. I want you work out as much as you want. I never take exercise away from my patients. Most of them already figured out what not to do and what to do anyways. I don't really talk about it too much. I just like, do whatever you want to do, because I need the information anyways to treat you off of. Because what are you going to do? Sit on your chair all day and you feel great? And then you come in here, and how will I be able to help you if you don't have that exercise to be able to tell you what feels different?
Mm-hmm.
So if I had to tell my patients to help themselves, I am a big component of, you can work your core in the gym forever, okay? What's more important is making sure you take that core that you feel like you're developing in an exercise environment and using it passively while you sit, actively when you get out of the chair, when you stand, when you get in the car, when you are walking, when you're stairs. It literally should be on at some point within, depending on the degree of activity, it has to be engaged. And I think a vast majority are not engaged. So if I was looking at how they can help themselves, is kind of building this knowledge of knowing how to make sure I am using my core when I sit in a chair. And to me, it's, I call it the art of sitting. Posture becomes the ruler for a lot of these things. So how you sit will make your core work or make your core do nothing. And we're not talking doing a core activate, like a contraction while you sit. That's not sitting. I'm talking passive core. So the stack facilitates that. That's where posture comes in. The stack will start to get you into a more core advantage position. So that becomes a big building point of what they can do for themselves. Knowing that perfect stack when you sit, knowing the perfect stack when you stand, etc. And I will tell you, there has not been one patient that I've had in so long years who knows that nobody knows how to sit in a chair. Okay, and sit in a chair where it actually feels that my core is dominant and my paraspinals are secondary. So I literally teach people how to sit in the chair. So posture becomes a ruler. The other thing I would tell them is, the big staples are posture and stack and firing up that core. And to me, the core activation exercise is a warm-up exercise for everybody who works out, and you know it well. And just getting the electricity so that that map brain, it's on the top of the pile, it's not on the bottom of the pile. When you go into your next squat and you go, and you might see this in your gym environment that, hey, we warmed them up and we got their core woken up a little bit, but they teeter out after 20 minutes of my session, okay? So they don't necessarily have endurance. So you have to kind of ballpark and kind of look at, like, what's the endurance of that core? Because if they're starting to lose their technique, I tell my patients, stop, reactivate, do it again. And they kind of learn when they need to plug it into their day. And my runners who can't run, they activate before they go run. They activate at 1 mile. They activate at the next mile. They activate at the next mile until they're clean. And then they can skip to 2 miles, and then they can skip to 3 miles, and then they're good to go, and they're intact endurance-ly. Their core is dominating their stabilization, the whole motion. So it's a big postural stuff that they can do, as well as knowing how to activate. And you know this from me, that there's this loose core workout, right? You know it well. Like, what exactly is it, and really how do you make it really specific? It doesn't have to be this rocket science exercise. It literally has to be just like this specificity with it.
Yeah, to target, it has to be at the right intensity to target those smaller muscles.
I always say it's like your spine just got a little bit of a hug. It just, somebody went through the spine and just did this to it just slightly.
Yeah.
That's the sensation it should be feeling like.
Yeah.
So
and that's the tough. I'm sorry, go ahead, Sam.
No, I was just going to say, and so when we have these discussions, Joanne, because, you talk about when we bring these up and kind of talk to them on a next level, not necessarily from a training perspective, but it actually becomes very important from a training perspective, because these are foundational pieces of movement. And because your daily life is 99% of these types of movements, the sitting, standing, walking, etc., it becomes such an important component from the training perspective, because that's what sets you up for success, eliminates and or minimizes pain or dysfunction, increases your ability to, from a mobility standpoint, but fatigue also becomes one of the biggest components, because those smaller types of muscle groups, if they're not properly trained, they fatigue out sooner. And that's what, typically would lead to those types of injuries. And so when Joanne talks about these basic movements, they really become an incredibly important foundational piece for all mechanics, for all movements.
Yeah, I like that.
Yeah, so I train them in endurance. I first train them for activation, and that would be like a warm-up exercise that you already currently do work with your clients. Mm-hmm. And then I train them on, okay, you're starting with a 10-second hold. Now you're going to 15. Now you're going to 20. Now you're going to 20, 25, and 30. And I kind of max out at 30, because most of the research says that if you can activate solid for 30 seconds, you've got a good endurance on spinal stabilization. And so I'm big on long holds. And if they're in a dysfunctional movement pattern and certain part of their squat looks crummy, pause halfway, reconnect, continue, and pick their little funky spots and make sure they're spinal connected, and just pause them out at that point.
Yeah, I like that. As you're saying that, I'm becoming self-conscious, and I'm sitting tall in my chair. But
I have that effect on people.
Yeah. So so this has been great. Again, thanks for taking the time. Can I tell you my
pet peeve though?
Yes, please.
From an exercise trainer point of view, and you know this of me, when patients come to me and they have personal trainers and they say, well, it's okay because I'm going to a trainer and I have shoulder injuries and they're not doing anything for my shoulder, so I'm good. And I'm like, oh. So I'm the one, much to your surprise, but not to your surprise, to other personal trainers' surprise, that I'm telling them, no, I want them to do 1, maybe 2 exercises, and this is what you're going to do. You want me to tell them to do that? I'm like, yeah, I want you to tell them to do that. So I think that there's this fear, and I say, if you don't know what to do and you're worried about pain, I say, do the range with little to nothing weight that looks clean, and only do that range. Because at least you're training something that is giving you some neuromuscular enhancing in that body area. And you might find that the next time you do it, you've opened up 5 degrees and open up 5 degrees. We don't know. It depends on what other dysfunction is going on. But at least you're doing something in that zone without creating this, COVID on the shoulder that they're doing nothing for 6 months, right?
Right. Yeah. Yeah. So if you have a dysfunction, address it. Don't ignore it, because it's not going to get better.
And do it methodically, do it strategically, do it with some thought, and just use your symptoms as a guidance on what I do and what I don't do, as opposed to complete avoidance, because we don't want a COVID shoulder that's really just stiffness, right? Because you haven't done anything with it for the last 8 months, because I'm scared because it's painful.
Right. Yeah. Yeah. I think a lot of people.
If you don't know, you ask your PT if they know.
Absolutely. If they don't have a PT, they can ask you.
Yeah,
so, and speaking of which, so how can people get in touch with you? Where you're located? They want to find more information, all that stuff. Ask you where you got your classes.
We're at 909 Purdue Avenue in U City, right around the corner from you. When you take the wrong turn coming out of your place, you'll probably hit me. And then you can go on the website, which is boutiquephysio.com. There's a link on there for info requests, appointment requests, even just information. We do consultations for patients that don't know if what we're providing is what they're looking for. And that's kind of the gist of it.
Okay. All right. Well, thanks a lot. And all those links will be in the show notes. Just go to catalyststl.com/podcast and search for this episode of the show, and all the links to contact Joanne will be Joanne and Sam, and they will be right there in the show notes. So guys, thanks again for taking the time. It's always a pleasure.
Thank you so much. Appreciate it.
All right. Have a good rest of your week.
You too. Bye now.
Okay. Bye.
All right.